Dr. Hanna, TTR tetramer stabilizers. The idea is to keep the four proteins together and prevent the monomer from being released and misfolding. There are a couple of agents, tafamidis and diflunisal. Can you take us through the important results of the international trial? We'll focus on cardiomyopathy with tafamidis.
Okay, well, the Attr Act Trial, which is testing tafamidis versus placebo in patients with transthyretin cardiac amyloidosis, and that's both wild type and hereditary, basically took 441 patients, and patients were randomized to 3 arms, either in a 2:1 and 2 ratio. So either tafamidis 80 milligrams, tafamidis 20 milligrams, or placebo. And the trial lasted 30 months, and they took the pooled tafamidis group, both those that were on 80 and 20, and compared them to the placebo group. And ultimately, the primary endpoint was a very hard endpoint. It was all-cause mortality plus frequency of cardiovascular hospitalizations. And there were secondary endpoints looking at the Kansas City Cardiomyopathy Questionnaire, which is a quality of life metric, and also at the 6-minute walk distance. Again, it's 0 and 30 months. And the results were quite striking in that, as far as all-cause mortality in and of itself, there was a very significant 13.5 absolute risk reduction in mortality. So about 71% of patients at the end of 30 months were alive, and those who took tafamidis, and about 57% of patients were alive, and those patients who took placebo. So that was a very striking. It was ultimately a 30% relative risk reduction in mortality. The same went for hospitalizations, a very significant reduction in frequency of hospitalizations. And as far as the 6-minute walk, the secondary endpoints, the patients, the decline in the 6-minute walk was much, much less over the 30 months in the tafamidis group than it was in placebo. I think there was about a 70-meter difference, 80-meter difference by the end of those 30 months. And the same thing goes for the Kansas City Cardiomyopathy Questionnaire, a very substantial difference in that the quality of life declined at a much slower pace in the patients who took drug, tafamidis versus placebo. So this was a very positive trial. The number needed to treat to save one life was about 1 in 8, which is, as good as we have in cardiology. That is treat over 1 patient over 30 months. So that translated to tafamidis FDA approval in May of 2019 as the only FDA-approved stabilizer or treatment right now for ATTR cardiomyopathy. The good news about this trial was the safety was excellent. There were more adverse events in the placebo group than in the tafamidis arm. There was no signal of a safety issue. So here we have a very effective drug that's taken orally once a day that not only has a mortality benefit, a decrease in hospitalization, a quality of life benefit, but it's also safe.
Okay. Dr. Desai, is tafamidis the ultimate goal of therapy? Do people truly stabilize, or is this just a slowing of their disease?
Well, I think that we have the sort of 30 months of follow-up in the Attr Act Trial, and that tells us that over that time interval, at least, we see improvements in survival, as mentioned, and also stabilization of the disease. I don't think we have longer-term data to really tell us whether the disease is truly stalled or the progression is actually simply slowed over time. My impression is that this is not an indefinite cure for the problem. It's rather an approach to stabilization of the protein and stalling disease progression. But that's quite meaningful in a disease with very limited overall survival. I think the other point to make about Attr Act is to add to Dr. Hanna's points is really that the bulk of the benefit was in those patients in the earlier stages of disease, the class 2 patients. The 3 and 4 patients got a little bit less benefit over the course of the trial, and it may speak to the fact that some patients may be a bit beyond the reach of rescue with tafamidis. And I think it's probably worthwhile considering in the context of the overwhelming cost of the agent to patients. When the drug was released, I think the annualized cost was almost $250,000 for patients. Fortunately, with subsidies, many patients can access the drug at far less of a cost. But I think it's another reason to build on what Dr. Botella said earlier, that these patients really ought to be seen at specialized centers who have the experience of securing the drug for the patients.
And Dr. Hanna, at the end of 30 months, the echocardiographic features of disease were improved or unchanged?
Well, this is something we're looking at. There is no published data discussing what's happened to, the echocardiographic features at baseline to 30 months. Ron, I don't know if you can speak to that.
Yeah.
Or...
Yeah, so I'd emphasize that patients with transthyretin amyloidosis, their echoes tend not to change that quickly, but far more important than what the echoes show is what happens clinically to the patients. And we know from Attr Act that the average patient worsens on tafamidis very clearly. You can look at the quality of life curves, and you can look at the 6-minute walk times, and clearly the patient's disease progresses over the 30 months. It just does so at a markedly slower rate than those on placebo. So I'm always very careful when I'm starting a patient on tafamidis to make sure that the patient and their family understands. Do not take this thinking you're going to feel better. In fact, take this with the expectation that you'll probably feel worse a year from now than you do today, but that you're going to be hopefully feeling significantly better a year from now than, or 2 years or 3 years than you would have otherwise felt if you were not taking it.
Okay, a very quick question. This is going to be quite controversial. It appears, my understanding is that the VA system nationally recommends initiating tafamidis at 20 milligrams. Your very brief comment about whether this is appropriate or this should be reconsidered. Dr. Wood, tell us.
I think yes and yes. It should definitely be reconsidered. It's amazing that you have, so 20 milligrams is not an FDA approved dose. It is incredible to me that the VA, a federal institution, would prescribe a non-FDA approved dose for patients. Why they're doing it is because in Attr Act, the 20 and the 80 milligram groups looked very similar to one another. And so the idea was, given the cost that Dr. Desai noted before, hey, if you could give them 1/4 of the dose, maybe you'd save a lot of money. So that's why it's not that it's unreasonable, but they are using a non-FDA approved dose. I think the jury's still out, particularly with longer-term follow-up, as well as with patients with hereditary mutations, if 20 milligrams will be as good.
Dr. Hanna, feel any different?
I agree with everything Dr. Wattel's stated, and there will be analyses looking at 80 versus 20 milligrams, but nothing that we can discuss at this time.